I'm gonna get started. There's a decent bit to go through. I'm gonna try and make eye movements as easy as possible for you guys, and so then we get a lot of hands-on at the end. So today we're gonna try and blend all three systems that go into eye movements. That includes the vestibular system, the actual eye muscles, and the cerebellum. What try are you guys? Three. So you've had both neuros, so you're a little familiar. Okay. Have you heard of VOR?
Yeah.
Yeah. Okay. So we can go through that. Have you heard of this? Lower six system. Okay. Great. It's kind of great not having to explain all the basics, so we can actually practice and get into the good stuff. Know all the different eye movements. Want to go through them?
Yeah.
Superior. Okay, so lateral rectus. Obviously, that's the easiest. It just abducts the eye on either side. Medial rectus adducts the eye. The elevators are superior rectus, inferior oblique, and the depressors are inferior rectus and superior oblique. And the other motion that they do, any of the eye muscles that begin with superior, so superior rectus, superior oblique, they're intorters, turn the eye towards the nose. Any muscle that begins with inferior oblique and inferior rectus, they're extorters, they turn the eye away from the nose. These are where the cranial nerves come out in the brainstem, and where that gets important clinically is when you're testing that specific area, or if you're testing a specific eye movement, and there's an issue with a certain area in that brainstem. So it could be the actual cranial nerve itself, or there could be an underlying cause in a different area of the brainstem. So if you're testing oculomotor, you're thinking more midbrain. Superior oblique comes out of the posterior brainstem. And another thing to remember, superior trochlear nerve is the only nerve that decussates out of the cranial nerves. So that's the only one that crosses over to the contralateral eye to innervate it. And then abducens nerve, we're thinking more pons. So when you're doing horizontal eye movements, we're activating more of the pons.
Does it decussate back, like forward?
The trochlear?
Yeah. So
it comes out of the
and
posterior brainstem and crosses over.
immediately, like posterior, or does it come in front and then cross over? You know, I've never heard that.
That's a good question.
I think it comes around the brainstem,
Okay.
and then decussates over.
Okay.
I'm looking it up.
Actually, it might decussate in the brainstem and then come out on the side that it innervates. So when it comes out, it looks like it's ipsilateral,
Yeah.
but I think when it's actually in the brainstem, it might decussate in there
Okay.
and then come out on the contralateral side.
Yeah.
That's
From this picture, it looks like it decussates right as it's exiting to make it look like it's on the same side, but it's starting from the opposite nucleus.
Okay. Gotcha. Thanks.
so.
I should have known that either.
This is how the cerebellum plays into eye movements, how it integrates. So anytime you're looking up, whatever side you're looking to, it's the same side cerebellum. Whereas if you're looking down and out to a side, it's the opposite side cerebellum. So that's when if you're doing the H pattern test, instead of just doing the H, if you start doing those diagonal eye movements, you're testing the same side cerebellum, whether you're looking down or up. So if you're starting looking down and to the left, and then you move up and to the right, that whole thing is testing the right cerebellum. Whereas opposite, down and to the right, up and to the left cerebellum. So that's how you can kind of bias when you're looking at someone's eyes. Do you guys want to go through this? It's just the basics. If you're just looking at eye muscle movements, what nerves are being activated and what muscles. So if you're looking to the right, right lateral rectus, left medial rectus, stuff like that. Looking up, that's the elevators on both sides. Another thing to remember, if you're just looking at these basic eye movements, like here, if you're looking up, if you're looking straight up, you're activating the 4 muscles, 2 on each side, the elevators, the superior rectus and inferior oblique of each side. Same if you're looking straight down, you're looking at the inferior rectus and superior oblique on each eye. So only horizontal gaze, you're using 2 muscles. If you're looking somewhere else, if you're looking straight up or straight down, you're using 4. If you're looking down and out, right eye, inferior rectus, left eye, superior oblique. And so I think next slide is where, yeah. So this is how you can kind of blend the vestibular system, cerebellum, and eye muscles into someone's head position and where their eyes are looking. So when you're doing the VOR, that's head movement, eyes stay fixated on your target, so no matter where your head moves, your eyes remain looking straight at your target. And so that's all 3 of these systems working together to kind of integrate and produce the compensatory eye movement in that direction. So when you think about it, if your head's back and to the right, what canal are you activating from the vestibular system? What canal?
Posterior, we see.
Right posterior. So right posterior canal. Which side? Cerebellum. So when you're tilting your head back and to the right, to stay looking at your target, your eyes are going to go down and to the left. So like we said before, if you're looking down and to the left, which side? Cerebellum?
Right.
Right. And then what eye muscles?
You're down to the left.
Yep, looking down and to the left. So left eye,
Would be the superior oblique, inferior rectus.
left eye, down and out. Right eye would be superior oblique, left eye, inferior rectus, yeah. Yeah, so this is a really good slide to go through different types of head positions, what's all being activated during that VOR movement. So something you can kind of play around with, and even with yourself, is like, okay, if I just tilt my head straight up, I'm gonna look down, what eye muscles are being activated, what's that cerebellum, blah, blah, blah. Because if you're looking at a patient, this is where you need to be like on the spot as you're looking at their eye movements, their head tilts. You need to be thinking and know right away, okay, what's being activated as I'm doing this, if you want to get really good at diagnosing what's wrong. And then, so when you're actually doing an exam and you see an abnormality, it's kind of like just the opposite. So an easy way to think of it is when you're looking, say, for example, if you have the right oculomotor nerve palsy, if you're looking straight, what muscle, so if you're looking straight, the eye is drifting out, first step you're gonna think of is what muscle is working. So if your eye is drifting out, lateral rectus on that side is working. So then you think, okay, well, what muscle isn't working? Medial rectus. And then that's where eye tracking comes in. If you're gonna be testing, if you find a direction where an eye drifts or doesn't go that way, then you think, okay, well, what muscle is working? So then the opposite muscle that opposes that motion, what isn't working? And once we start practicing, I'll pull up a nice picture from the diplomate is to kind of practice that involves head, like chin up, chin down, rotation, and right and leftward head tilt. Alright, we're gonna go through the different types of eye movements that you're gonna be looking for in testing once we break up in practice. Smooth pursuits, that's just following an object, like follow my finger, your eyes are moving smoothly in unison, and that's going to correlate to the same side parietal lobe. So if I want to look to do a smooth pursuit to the right, testing right parietal lobe, smooth pursuit to the left, left parietal lobe. Saccades are those quick jumps, like if someone walks in the door right now and your eyes shoot over because they hear a noise, those are going to correlate to the contralateral frontal lobe. So if my finger's over here, I'm looking straight, then I jump to the right real quick, that's going to be from the left frontal lobe. So pursuits, same side parietal, saccades, contralateral frontal. So convergence and divergence, that's follow my finger, an object far away, convergence, divergence. So you're testing here for if they get any double vision and how far away it is if they get double vision. Like someone's right here, I get double vision, that's not normal. Everyone will eventually get double vision when your finger's right on you because your eyes are opposing each other. Vergence is strongly influenced by the midbrain. So again, just to keep it simple, since we only have 50 minutes, if you guys want to dive in deeper to stuff, talk to me afterwards. But we're remembering pursuits, same side parietal lobe is what you're testing. Saccades, opposite side, frontal lobe, vergence, you're thinking more of a midbrain issue. Anyone know why you're thinking more midbrain? What are you using? What eye muscles are you using? If you're looking at medial rectus, what's that innervated by? Three. Where's three come out of? Midbrain. See, anatomy. Accommodation. Again, that's changing your pupil size and your lens size. If you're looking at something far away, as opposed to if you're looking at something close up. So when you're looking at something far away, your lens will flatten out and your pupil will dilate. As opposed to when you're looking at something super close, your pupils constrict, your lens becomes more round. And it's just a focusing thing. Optokinetic reflex. Either of you familiar? Chris is yeah. So this is just basically combining pursuits and saccades. So that strip up there is an OPK band, and it's how you can test. Basically, it's like the example on here. If you're watching a train, so the train's going by, so you're following it. Once it gets out of your field of vision, you saccade back to look at the next part of the train, goes back. So it's kind of that movement.
I have it here.
And she got it up. Yeah. So you can change the speeds on it. You can do vertical, horizontal. So when we're using, if we're looking at horizontal eye movements, we're activating more pons, whereas vertical or midbrain.
Like you can do diagonal.
Do that too if you're looking for more cerebellar activation.
You can even, this is my favorite. You can do monsters.
Yeah.
Doesn't matter what you're watching. No.
And so, as it says here, you can bias one hemisphere over the other, because if you think about it, if you're pursuing to the right, that's same side parietal, so right parietal, then you saccade to the left. If you saccade to the left, right frontal. So that's how you can kind of bias either side. And then if you're going vertically, again, that's more midbrain activation, because for the same reason, that's more oculomotor and trochlear nerve as opposed to abducens. Yeah.
What does it look like if somebody struggles with this? Like, what would not failing the test, but like, what would you think we need to work on this more? What would it look like for the patient? Like,
Define failing.
like, if you think they have a problem, would it be in the saccade or like the pursuit more commonly, you know? Or like, is this more of just a rehab tool?
Test and more of a rehab. I would say if you want to see what movement is failing more, test them individually rather than just the OPK reflex. So do follow my finger for pursuits, and then thumb to nose. And then if they have a problem with that, then you already know, okay, if they're struggling with that, then their OPK is definitely gonna be messed up. But here, this video, you can kind of see what it would look like if, and again, this is why you do both directions, because
Optokinetic nystagmus is a visually induced nystagmus that can be stimulated with a piece of striped material moving backwards and forwards in front of the patient's eyes, or with the striped drum as shown in the video. The nystagmus should be observed in the horizontal and vertical planes, and you should look for symmetrical eye movements to both right, left, up and down. The fast phases of the nystagmus, i.e. the saccades, are in the opposite direction to the drum rotation.
Do you see that difference?
An asymmetry of nystagmus is suggestive of a neurological rather than labyrinthine disorder.
So then you can kind of extrapolate from that. Okay, say she heard saccades, if whichever direction it was, saccades to the sky were fine. So then her elevators are fine. But then she would struggle if she was saccading downwards. Maybe her depressors aren't working. So you can kind of pick and choose which muscles you want to look at more.
You might have already talked about it, but in that particular, like, just how it's going, in the case of somebody with, like, who gets really motion sick, would,
Like the speed, are you talking about?
like,
Or-
any of it, like, what, would you just hope that they don't, like, it, or what?
Potentially. So it would depend why they're getting motion sickness. Is it a problem with their eyes? Is it a problem with their cerebellum or their vestibular system? So like you can do Dix-Hallpike, see if they have something like BPPV. If that's negative, you test their cerebellum, do Romberg's, dysdiadokinesia, stuff like that. That's negative, well then maybe it is an eye movement. And then again, do eye tests, see if there's an abnormality, and then go after that.
Okay.
So again, we're blending these all together, but you want to test them individually, at least at first. Or you can test them globally and then you see something's wrong. All right, now I want to break it down and test each system individually. And that's how you go about your exam. So nystagmus, the thing you want to remember with a nystagmus, everyone just thinks all eye flutter movements are nystagmus, but with nystagmus, there is a fast phase and a slow phase. So it's basically the OPK. There's a like slow pursuit with a corrective saccade. So slow, fast. And most commonly you do see this in BPPV or or some type of vestibular issue. And you guys both know what BPV is? Yeah. So when you do that Dix-Hallpike maneuver, because that otoconia is out of balance, when you tilt their head back, if it's a right posterior, we'll go with. So, like we said before, when you tilt your head back into the right, your eyes want to correct by going down and to the left. So that's your VOR correction. But if you have an otoconia loose, you're getting extra stimulus from that vertebral canal, and the more stimulation is telling your brain that you're falling backwards, you're continuously falling backwards when your head is tilted back and not moving. So there's a mismatch between the systems. So that's why if you have a right posterior, you'll have the VOR having a slow, smooth pursuit down into the left, and then you'll have a quick corrective saccade up and to the right towards that posterior canal. Again, so the nystagmus that actually occurs is dependent on which canal is misfunctioning. And if your horizontal canals are misfunctioning, you'll have a horizontal nystagmus towards that same side. If it's an anterior canal, it'll actually be opposite. So when you go tilt your head forward into the right anterior canal, but your eyes want to go up and to the right. But if your vestibular system is telling you I'm falling forward, there's going to be a corrective saccade away from that vertebral canal. So posterior canal, the saccade will be towards that. Anterior, the fast phase will be away because it thinks you're falling forward, so you want to look down and in, and the VOR is telling you to look up and to the right. So that's as simply as I can break it down for you. I'll play these videos later if you want to watch them, but we can get hands on first. Blind spot mapping, the last thing we're going to go over, and I think it's a great objective measure that you can use for any of your patients, because everyone has an optic disc in their eye, and with your optic disc there's no rods or cones, so you're not receiving any sensory information from looking visually. So everyone has a blind spot in both of their eyes. So when you cover one eye, you take that away and they'll have a blind spot somewhere in this area. So to measure it, you basically, they have machines to do this, but you don't need it. You can have, like I use, a piece of paper, something that's used a little fine tip as a marker, because the blind spot's not very big, as you'll see when we map each other's, and you just do left and right eye. And I'll explain it to you when we go over it. But yeah, that's all I have. So we can do H pattern, eye movements, test pursuits, saccades, convergence, divergence, map blind spots, everything else. And then you just go through different head positions and what 3 systems are being activated with each one. So, sound good? If you guys want to do each other's blind spots first, I'll walk you through it.